Yeah, thank you for giving me the opportunity to talk about my presentation at San Antonio. I presented updated follow-up data of the MINDACT trial, and the MINDACT trial ran from 2007 to 2011. It included patients in 9 European countries, including the UK, to understand which patients, based on a clinical risk assessment of their first diagnosis of breast cancer, so it's about early diagnosed patients, the clinical and pathological diagnostic assessment integrated with genomics signature of their breast tumor tissue, and that was the 70-gene prognosis signature MammaPrint. How can we combine those two and understand of patients who are then low risk and low risk by the one, or low risk by one of those and high risk by the others? How should they be treated? And particularly we're interested in, do they all need chemotherapy, or is there a group where we can safely forego chemotherapy? So on the updated results, we show that women that are postmenopausal, if they are clinically high risk and MammaPrint low risk, that their survival is almost exactly the same with or without chemotherapy. They have an 8-year survival without recurrence of their disease. That is, first of all, really good, about 95%. But secondly, it's only 0.2% survival difference. So there's really no benefit of chemotherapy. So the trial also studied, of course, patients who are both who are clinically low risk. And my presentation at San Antonio was to highlight the results of those that are low risk and what do we identify in those and how can they be better managed. So what we showed was that if patients can be, 81% of the patients were both clinical and MammaPrint low risk, then their survival is extremely good. At almost 9 years, their survival is also about 95%. And those that are clinically low, but their tumor biology says high risk, there's about a 3% survival difference. So their almost 9-year survival is 91%. So the question then is, how do they benefit from chemotherapy? So this was a very small group, so we didn't have that much power. So we couldn't show any benefit from chemotherapy, but it remains that if the tumor biology says high risk, that the whole group has a survival of 91%. So we need more data to further understand if really the chemotherapy gives a survival benefit. But suffice it to say that clinically low risk patients to begin with as a group already have a very good survival. But if the tumor says high risk, the decreased survival does sort of indicate that some adjuvant treatment might be beneficial. Maybe first of all, again, let's look at the age difference. So another way to look at tumor biology and prognosis prediction, besides MammaPrint, which we have been studying in MINDACT, of course, there's the test called Oncotype that has been mainly used in hormone receptor positive patients, but for comparison in MINDACT, we also look just at the hormone receptor positive HER2 negative patients. So for both trials, TAILORx and MINDACT, and now also RxPONDER for women diagnosed as of age 50 that are clinically high risk and genomic low risk, there's no survival benefit from adding chemotherapy. So that's very clear and very good news for women diagnosed when they're postmenopausal over age 50, which is the majority of all breast cancer diagnoses, that clinical tests such as MammaPrint and Oncotype can help to decide if chemotherapy is needed. Because, of course, if you're clinical high risk and genomic test high risk, so to speak, high, then chemotherapy does give the benefit for survival. But if you're clinically genomic low, then both trials, or those 3 trials, now show that there's no benefit of chemotherapy. So MINDACT included both lymph node negative and lymph node positive patients, up to 3 positive nodes. TAILORx only included lymph node negative patients, and now RxPONDER has added that same result for patients with 1 to 3 positive nodes. So it's for now for lymph node negative as well as 1 to 3 positive node early breast cancer patients. It's clear patients diagnosed under 50, if the genomic says low risk, then they can safely forgo chemotherapy. So then to turn to the premenopausal patients diagnosed below age 50, all 3 trials also show the same, that for patients that are clinical high risk and genomics low risk and diagnosed under 50, there seems to be a benefit of chemotherapy of a few percentage points, depending on which study and which test. It ranges from, I think, MARPRINT, almost 5% to Oncotype between 6 and 9%. There is a benefit of chemotherapy, but this benefit seems to occur later in follow-up. And chemotherapy, besides the cytotoxic effect, also has a ovarian suppression effect. So the discussion has been up till now, and neither one of those trials can prove this. If patients in those trials were all treated with mainly only tamoxifen, there's like up to 15 or 20% who got ovarian suppression of these premenopausal women. If one would have added ovarian suppression as part of the treatment, either by a drug treatment or by removing the ovaries, which is sometimes done, would that have led to a survival gain similar to now what we see from chemotherapy? And so other trials, not MINDACT or TAILORx, have shown that ovarian suppression can give such a gain in survival. So now the question is, since this has not been formally proven in neither MINDACT, TAILORx, or RxPONDER, is the information from those other trials, like the SOFT trial, sufficient to actually recommend ovarian suppression? Or do the trials now lead to the conclusion that all these women need chemotherapy? So nobody knows the answer. It's up for discussion and being discussed. And so I think it's a conversation between the patients and the clinicians, what might be best in mostly her situation.